I would like to welcome you all to this 10th Europe Nurse Symposium conducted by Essentia, and the theme of our symposium in 2024 is Optimizing Life for Patients with Diabetes. Insights, better management, and innovations support individuals in their journey. I'm very flattered and to be here for this 10 years jubilee, and I hope this meeting will be interesting and that you're going to share new experiences with us. My name is Dr. Marina Andjelic Jelic. I'm consultant endocrinologist and diabetologist in Belgrade City Hospital. It's called the Zvezdara Medical Center in Belgrade, and I have been working for more than 20 years with patients with diabetes, and it's my main area of interest. Before introducing other members of our distinguished faculty, I would like to give you a few information on logistics. First of all, you have to know that the main language today is English, but you can follow this event in 7 different languages. This event will be available in 7 languages, and you see in the breakout room at the figure 1, you can choose a room to join, and if you wish to change your language at any time during this symposium, you can do that. Just go to breakout room, choose your language, and of course you can switch it at any time you like. For the live part of the session, for questions and answers, you will be automatically directed to the main webinar. I just want to mention that the questions and answers session will be conducted in English, and attendees can choose to get subtitles in their preferred language. If you click on caption, you can select the preferred language in order to see it as subtitle. So when select caption, you can then select the preferred language, and that language will be seen as a subtitle. And the last questions and answer session will be conducted in English. You can pose your questions whenever you like in Q&A button in Zoom. You can, of course, choose to get subtitles if you want in the preferred language, and in caption, you can select the preferred language as well. The members of our faculty are really distinguished, and as I said, it's a great honor for me to be with them. Our first speaker is Assistant Professor Miodrag Janić. He's attending physician in the Department of Endocrinology, Diabetes and Metabolic Diseases in University Medical Center of Ljubljana. And his topic is personalized medicine in diabetes and blood glucose measurements for CGM users, tailored therapies for achieving individual needs.
So hello, I'm very honored to be a part of Europe Nurse Symposium 2024. My name is Miodrag Janić, and I come from the Department of Endocrinology, Diabetes and Metabolic Diseases from University Medical Center of Ljubljana. The title of my talk, as you can see, is Personalized Medicine in Diabetes and Blood Glucose Monitoring for CGM Users. We are going to talk about tailored therapies for achieving individual needs. So these are my disclosures. So let me just emphasize about the personalized medicine, not to be confused with the precision medicine. In regard to personalized medicine, we refer to us clinicians caring for the patients and their individual needs, not the populations. That's not the populational medicine. It's the reflection of appreciation of individual with respect to symptomatology, presentation, behavior, comorbidities, clinical course, and so on. So it's the type of medicine where one size does not fit all, but is, let's say, tailored to individual needs of particular patients that we have in front of us. And as you know, the ADA EASD guidelines also present this decision cycle for person-centered glycemic management in type 2 diabetes. with two goals of care. That one is to prevent complications, and of course, at the end of the day, we all stream to optimize quality of life of our patients. Let me introduce you to Florian. He is an individual with diabetes type 2, and in regard to this holistic approach to diabetes medicine, we have to address life's 8 essentials that were introduced by American Heart Association. These life's 8 essentials are actually important for each and everyone, not just the diabetes patients, but nevertheless, in regard to diabetes, glycemic control is of importance, weight management, lipid management, arterial hypertension, non-smoking, also sleeping, healthy food or nutrition, and exercising. When we have a look at Florian, he is going through a journey of the chronic disease. In this particular subject, this is diabetes. And our educational nurses, here represented by Zofie, the educator nurse, have developed a special program in Slovenia called Tabletka program, or the pill, which is intended for people with diabetes who are being treated with tablets, not insulin. And this is for me, personally, very nice representation of a personalized approach towards education of a person with diabetes. It is, as you can see, this is, maybe you know, the valley of Triglav lakes. There are 7 lakes, and Florian is going through the journey where he, of course, with the help of Zofie, educator nurse, he is introduced to awareness of disease, the pathophysiology of disease. He is introduced to treatment options, also to nutrition, physical activity, about the importance of rest and relax. We don't talk enough about it. About his treatment targets, which we are going to talk about today as well, because they are personalized and not the same in every patient, and also about the complications. Also, once again, emphasizing at the end for a good quality of life when living with a chronic disease. And as you can see, this was also recognized, these all aspects of lifestyle in ADA EASD guidelines from 2022, emphasizing the importance of sitting and breaking up prolonged sitting time, stepping, sleep, sweating, so that's moderate to vigorous activity, and strengthening. And what is important in this regard, I see it is very important, is that there is also the influence of these aspects of life on different glycemic and non-glycemic parameters regarding glucose and insulin, blood pressure, HbA1c, lipids, physical function, depression, and of course, quality of life. As you can see, the plethora of evidence is a bit heterogenic, but nevertheless, all of these aspects influence the life of our patients. And in regard to therapy, the main or the base is healthy lifestyle behaviors, diabetes self-management, education, determinants of health. But we all know that we have to address the glycemic management and diabetes management with drugs as well. So these are also, in this regard, personalized in these new guidelines for 2022. Because we have 3 main pillars that we have to address in parallel, also in regard to drugs. So what kind of medicines do we give? First of all, we have to know if our patient has comorbidities, particularly atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. And we give the drugs that have a particular influence on reducing the cardiovascular events and kidney events. Then glycemia is important, and also body mass. This is a new pillar of therapy that was not addressed enough before, but now we know, because we have effective drug therapies, that it should be addressed parallel to the other 2 that I represented. When we achieve these goals, we have to reevaluate them and address them once again if they reappear. That this has influence and that the good glucose control is important, we know from the UK PDS. This year is 24 years from the beginning of that study, and we can see that early tight glycemic control is effective in reducing diabetes-related endpoints, myocardial infarction, and deaths from any cause in people with diabetes. While in regard to microvascular disease, we can see that you have to be even stricter, so very tight glycemic control with insulin therapy or sulfonylureas is important at the beginning of the disease in order to prevent long-term microvascular disease. And this is also seen here. As you can see, for both groups, or insulin-treated group and metformin-treated group, we can see that even after 10-year follow-up and 24-year follow-up, those who were intensively treated had benefit in regard to diabetes-related endpoints, diabetes-related death of any cause, and myocardial infarction, while only those with sulfonylurea or insulin group had benefit in regard to microvascular disease. And what about the macrovascular disease? We can see here that tight glycemic control does not, or we don't have enough evidence to say that it reduces the MACE, major adverse cardiovascular events, but still there is beneficial influence on reducing the non-fatal myocardial infarctions and also amputations and revascularization. And in regard to microvascular events, we know that tight glycemic control is beneficial, but on the other hand, in regard to safety outcomes, there is more severe hypoglycemia. So in each and every individual, there have to be individual glycemic targets. So in those with short life expectancy, with more comorbidities, with established cardiovascular diseases, and so on, we have to have more relaxed glycemic targets than in the individuals who are, let's say, younger, have less comorbidities, and have a longer life expectancy in front of them. And also, what I think is important, for the first time last year, also European Society of Cardiology, so their guidelines regarding the treatment of diabetes in people with cardiovascular diseases, recommend strict glycemic targets also to reduce the risk of coronary heart disease. As I showed you before, there is benefit of strict glycemic control on this outcome. So when we have a look in Florian's journey and how he is achieving these targets, we can use, and he must use, blood glucose monitoring. Why? Particularly to help him regarding the therapeutic decisions and therapy adjustments. So that's eating behavior, lifestyle, anti-diabetic therapy. Also to allow him for immediate treatment decisions, because we know that HbA1c is an estimator of long-term quality or of glycemic control. But when there are fluctuations in the shorter term, the blood glucose monitoring is very helpful. Early detection of hypoglycemia or hyperglycemia is important, prevention of complications. This also allows a person with diabetes better quality of life, and of course there and self-management, because he can make informed decisions about care. But we should bear in mind that there could be also potential negative consequences, like burdensome, because frail patients or those with cognitive or visual impairment and other impairments, this can be a burden to them. It can lead to high depression scores, because people think that they are not behaving good or they're behaving bad. Also, impairment of adherence and confusion about the value of blood glucose monitoring. There always should be, this should be used in regard for further interventions. And sometimes this can also shift focus away from other risk factors that are also important in people with diabetes. In regard to different glucose profile, when we use blood glucose monitoring, we know that check for glucose patterns or effect of meals, so we can check the glucose before and after meal, or fasting blood glucose. This is also important. Sometimes it calls for introduction of basal insulin. We can have 3-day glucose profile that allows us to better form and advise our patients further, change therapy. We can also check just for postprandial glucose excursions. We know that these add a lot to long-term complications, so we have to address them and maybe change therapy. One meal, 2-day and overnight patterns of checking, and also effect of physical activity, which is very important, particularly with older drugs that can cause hypoglycemia. So when we have all these data from the blood glucose monitoring, we have to process this data, and we can also do it remotely, like in this particular case, in order to advise our patients, maybe on a distance, or we can analyze it and then have a more intensive talk with them and tell them or advise them on change of therapy or change of lifestyle behaviors, or maybe just nutritional advice and so on. So when we have integrated personalized diabetes management, we start with the structured education, which I told you and showed you before. And we can add blood glucose monitoring, but it is important that we can document that and do a systemic analysis, because if we don't analyze it and there are no consequences of these measurements on our further adjusting therapy or adjusting lifestyle and so on, then this is particularly useful, and it could be burdensome, as I showed you before. And based on these systemic analysis, we can personalize the treatment for our patients and then regularly assess the treatment efficacy. So while we live in an era where CGM is practically available more or less now to everyone, some people buy it, some people also get it through the insurance companies, there is still situations where we need blood glucose monitoring, where this is still necessary. We know that CGM measures glucose in the interstitial fluid, so sometimes this varies from blood glucose, and we must use it when we suspect discrepancy between CGM and the symptoms or expectations of patients before making important decisions. During illness or stress, also during pregnancy, because accurate readings are here very important for also mothers, but in particularly babies' health. And sometimes CGMs need calibration. So ADA recommendations are that all people using CGM must always have access to blood glucose monitoring as well. And we know that CGMs offer convenience and real-time data, but blood glucose monitoring is still the gold standard and essential tool for diabetes management, especially when we need very exact accuracy and confirmation of the results. So CGMs are not substitutes for blood glucose monitoring, but we should use them complementarily. So instead of the conclusions, I would like to just say a few things about tailored therapies for achieving individual needs. We need to individually approach our patients to optimize their diabetes care and to recognize the unique needs and their unique characteristics, because each and every one of us is different. We need to address various aspects of their lifestyle, nutrition, physical activity, and we also have to prepare personalized treatment plans. As I mentioned, glycemic targets are important, and these should be individualized, because one size does not fit all, not just for glucose, but for all risk factors. We should be more strict in achieving glycemic targets in order to reduce the complications and also to reduce cardiovascular and microvascular diseases. Blood glucose monitoring is critical for informed therapeutic decisions. We can detect glycemic extremes, either low or high, and with reducing those, we can improve quality of life of our patients. And as I mentioned at the end, CGM, so continuous glucose monitoring, should be used complementarily with blood glucose monitoring for optimal management. So once again, I should emphasize that all aspects of diabetes management should be considered, and not just the drug therapy, but all the aspects of lifestyle, nutrition, physical activity, and cognition in order to prevent complications and also to allow for good quality of life of our patients, which should be, at the end of the day, our main goal. I thank you for your attention.
Our next speaker will be Sister Jodi Aigner, and she's an experienced long-term nurse from South Africa, working in Mbusa Medumblanga Private Hospital, and her topic will be self-monitoring of blood glucose in type 2 diabetes and long-term outcome.
Good afternoon, and thank you for this invitation to talk to you about this most important topic of self-monitoring of blood glucose in type 2 diabetes and long-term outcomes. Diabetes is an insidious chronic disease, and its incidence is growing rapidly worldwide. These are the global challenges that we are faced with. Note Africa. Previously, this was unheard of on this continent. This highlights the importance of diabetes self-management education and support, or DSM-ENS, and is provided by the very people present here today. Epidemiologically, type 2 diabetes affects millions worldwide, with numbers projected to rise due to aging populations and lifestyle changes. From a pathophysiological perspective, it's characterized by this insulin resistance, where cells become less responsive to insulin and impaired insulin secretion by the beta cells. This has dire health implications. Uncontrolled type 2 diabetes can lead to a whole host of complications in nearly every organ in the body. Years of poorly controlled hyperglycemia leads to multiple, primarily vascular complications that affect small or microvascular and large macrovascular vessels. Microvascular complications are specific to diabetes mellitus, whereas the macrovascular complications are not. However, people with diabetes have an increased risk of macrovascular events compared to people without diabetes. There is also a high frequency of atherosclerosis, which is a macrovascular complication. You can see here with the stroke, 200 to 400% increase in strokes and cerebrovascular mortality, an increase in heart disease, and in peripheral vascular disease. Up until recently, as the traditional algorithmic treat-to-fail approach has been adopted by many countries, and this has been changed in recent guidelines. And this was initially described by DeFronzo in 2009 as the ominous octet. Lately, guidelines have adopted this pathophysiological approach, which now uses initial combination therapies with complementary mechanisms of action known to correct established pathophysiological defects in type 2 diabetes. Within this latter approach, the choice of anti-diabetic agents is individualized, taking into account the patient's general health status and associated medical disorders, including age, body weight, and microvascular and macrovascular complications. So this ominous octet described 8 pathophysiological pathways, which included the brain, the liver, beta cells of the pancreas, including the alpha cells, the kidneys, the GI tract, and adipose tissue, as well as in the musculature. What we are very aware of is that it is clear that the epidemic of obesity is driving the epidemic of type 2 diabetes. Obese individuals who have characteristically had compensatory hyperinsulinemia in response to insulin resistance tend to have an increase in food intake despite elevated insulin levels. Of late, the term the ominous octet has now been adjusted to be called the egregious 11, which includes the microbiome of the gut, of the dysregulation of inflammation, amongst others. To understand current recommendations with regards to monitoring practices, we must first have a look at the most common oral medication that we use. And type 2 very often involves the use of oral medications to control blood sugar levels. These medications work through various mechanisms to either increase insulin production, improve insulin sensitivity, reduce glucose absorption in the intestine, or enhance insulin action. And you'll be very familiar with some of the oral agents, such as the biguanides, which include metformin, sulfonylureas, the TZDs, which include pioglitazones, the more recent additions of the DPP-4 inhibitors, such as saxagliptins and the SGLT2s, another more recent addition. The alpha-glucosidase inhibitors, which is not used that often in South Africa, and bile acid sequestrants and dopamine 2 agonists. A very common addition in South Africa particularly is the non-insulin injectables, such as the GLP-1 receptor agonists and amylin mimetics, and of course, insulin injectables. So why is it essential for good glycemic control? Well, glycemic control is important. I mean, monitoring of blood sugar levels allows healthcare professionals to assess how well diabetes management strategies, such as our medications that we prescribe, the diet, stress management, and exercise, and to identify if they are working to maintain stable blood glucose levels within target range. Regular monitoring provides real-time data to adjust these medications, our insulin doses, or lifestyle factors promptly, optimizing diabetes management and reducing the risk of complications. Thirdly, it helps detect fluctuations in blood glucose levels before they become severe, enabling timely intervention to prevent hypoglycemia, so our low blood sugars, or hyperglycemia, high blood sugars. Monitoring empowers our patients to take an active role in their health by understanding how their daily activities and food choices impact their blood glucose levels. This awareness can motivate them to make healthier choices and adhere to treatment plans. Individualized diabetes management is facilitated through data obtained from monitoring, allowing healthcare providers to tailor treatment plans according to each patient's specific needs and responses to therapy. And then finally, consistent monitoring is crucial for preventing or delaying diabetes-related complications, such as cardiovascular disease, nerve damage, and kidney disease, which can have a significant impact on quality of life. So what about the impact of inconsistent blood sugar levels on health outcomes? So this is known as high glucose variability. So when we have high glucose variability, inconsistent blood glucose levels, whether due to infrequent monitoring or other factors, this can have a significant impact on patients on their outcomes. Prolonged periods of high blood glucose levels can lead to acute complications such as diabetic ketoacidosis, as we see in type 1 diabetes, or hyperosmolar hypoglycemic state, which we see in type 2s. Over time, it contributes to long-term complications such as I mentioned previously, cardiovascular disease, nerve damage, chronic kidney disease, and eye problems. It also low blood sugar levels resulting from erratic medication timing or mismatched insulin doses pose immediate risks such as confusion, dizziness, and if severe, loss of consciousness or seizures. Recurrent hypoglycemic episodes can also lead to impaired awareness of hypoglycemia and increased cardiovascular risk. And you can imagine the impact this would have on our patients who live alone or our elderly patients. The impact this may have on quality of life. Fluctuating blood glucose levels can impact daily functioning and quality of life. Symptoms like fatigue, mood swings, and difficulty concentrating are common during both hypoglycemia and hypoglycemic events, affecting work, social interactions, and overall well-being. In progression of diabetes complications, inconsistent blood glucose control accelerates the progression of diabetes-related complications. It amplifies the damage again to blood vessels, nerves, and organs, worsening outcomes over time despite treatment efforts. It also makes it actually really difficult for healthcare providers. It gets very difficult to manage an inconsistent blood glucose when one has to keep adjusting medication and recommending different lifestyle modifications. It makes it very complex, and it requires frequent monitoring to tailor treatment plans based on real-time data. And then, of course, we can't get away from the fact that there is always a financial burden. Uncontrolled diabetes and its complications impose significant healthcare costs on individuals, healthcare systems, and society as a whole, emphasizing the importance of effective monitoring and management strategies. As you are all European nurses, I took the liberty of including guidelines written by your own authorities, such as the EASD, which you'll know is the European Association for the Study of Diabetes. And I use these guidelines throughout my talk today. As you're also no doubt aware, the EASD and the ADA published this consensus report in 2022, which may be found online. And this one was published in Diabetologia. And their position statement emphasizes that individualized treatment goals and therapeutic strategies are the cornerstone of success in persons living with type 2 diabetes. They make mention of the fact that diabetes should be monitored, often through self-monitoring of blood glucose, or SMBG, or continuous glucose monitoring, which is becoming far more common. What a crucial role this plays. So we can't get away from a topic without including guidelines and targets. And I've included the ADA's recent additions, where we have pre- and post-meal targets that we like to achieve, including the HbA1c. HbA1c remains to be the metric used in clinical trials, although we are starting to see the time and range being used a whole lot more frequently. But what the ADA include is the rationale. More or less stringent glycemic goals may be appropriate for individual patients, and they quantify it a little bit further. HbA1c twice a year in patients who are meeting treatment goals, or quarterly in patients whose therapy has changed or who are not meeting goals. I myself love to use this particular feature, where I stratify my patients according to the ADA guideline, where there are patients who have potential risks associated with hyperglycemia or other drug events, whether they need to be more or less stringent, how long they've had standing disease for, how long their lifespan is expected to be, whether they have many or few comorbidities, whether they have vascular complications, what their attitudes are, and whether they are motivated or not, and whether they have a better support system or very limited. And this does assist in making or determining a good HbA1c target between myself and my patients. I furthermore just included this decision cycle for person-centered glycemic management in type 2 diabetes, as everybody, no matter whether you are a diabetes nurse or somebody on the multidisciplinary team, it includes guidelines that provide ongoing support and monitoring of all aspects of emotional well-being, lifestyle and health behaviors, tolerability of medications, and it includes the biofeedback, including blood glucose monitoring or CGM, continuous glucose monitoring. So look how far we've come in the past 50-odd years. Some of these devices look positively archaic, but you can see how the meters that we've used and the devices, the lancing devices, they have just made our lives so much simpler for our patients. So when it comes to self-management of diabetes, the structured and personalized self-monitoring of blood glucose provides a systematic approach to tracking blood glucose levels, helping to identify significant daily patterns. This method is increasingly important in managing diabetes. So it's no point in just sending a patient off with a diary and say, off you go, test once a day. They need to know what they're doing it for. Why are they testing? SMBG is a well-established and valuable tool for managing type 2 diabetes. Additionally, it's been proven beneficial for achieving long-term glycemic control in type 2 and aids in preventing both acute and chronic complications. Self-monitoring enhances patient awareness of hypoglycemia, enabling self-regulation to prevent severe hypoglycemic episodes, amongst other benefits. Let's have a look at some of these. So the idea is to get your patients monitoring with meaning. So it needs to be accompanied by structured education programs to facilitate behavior changes and ensuring that the patients have improved outcomes overall. We need to teach our patients how and when to perform SMBG, how to record, what is the meaning of various blood glucose levels, how certain behaviors and actions affect blood glucose levels. Now, these are just some examples of different profiles that we can teach them. There's 5-point profiles on the left, underneath the 7-point profiles for 3 days and consecutively. There's a staggered approach. There's another approach which says meal-based before and after meals. Then there's something to look at with the patterns of fasting hyperglycemia or perhaps hypoglycemia. So there is no one size fits all. And I found a wonderful tool online that has been identified. I've included the site for you, which is by Diabetes Canada, which will identify your patients. You simply add in which type of diabetes they have, what target you'd like to identify for them, which medications they're on. And it actually spits out a schedule that would be ideal for them. So you simply print this off and give it to your patients. Now, I realize this is all very wordy, but ultimately the ADA and this is Diabetes Canada 2018, identifies that if your patients are using more than 1 insulin dose a day, they should be testing at least 3 times a day. For patients who are on once a day insulin, you want to be testing at least once a day at different times. For patients not receiving insulin therapy, it all depends, and it should be all individualized, depending on the type of treatment that they're on, what their control is like, and whether they have a risk of hypoglycemia. In many situations, for all individuals with diabetes, more frequent glucose testing should be undertaken to provide information needed to make health, behavior, or anti-hypoglycemic medication adjustments required to achieve desired glycemic targets and avoid risk of hypoglycemia. People with diabetes should be provided with a blood glucose monitoring devices indicated by their circumstances, preferences, and treatment. Patients who are on insulin should be encouraged to check their blood glucose levels where appropriate, again, depending on what kind of or how many times a day that they're on their insulin. Very importantly, when it comes to the accuracy of meters, is that the ADA is very particular about identifying accurate meters and patients being able to be given accurate meters, and they say only meters approved by the US Food and Drug Administration or meters by comparable agencies such as European Union may be used. These 2 bullet points at the bottom as well are very important. Monitoring in individuals on non-insulin therapies has not consistently shown clinical significance, but it may be helpful when altering nutrition plan, physical activity, and or medications. And lastly, healthcare professionals should be aware of medications and other factors such as high-dose vitamin C and hypoxemia that may affect readings. So current monitoring, tailoring monitoring frequency and methods to each patient's specific needs and lifestyle will be able to optimize our glycemic control. We've got patients who will be able to use continuous monitoring for patients who are on insulin, and less frequent monitoring for patients who are not on insulin. We have come such a long way from the past. We are looking at technology that is able to use sensors that will look at glucose levels under the skin and the interstitial fluid, which will use either continuous glucose monitoring or flash glucose monitoring. And there are innovative solutions that are currently not yet in the market, but are certainly in the process of being identified. So we've got some exciting technology in our pipelines. So in summary, more frequent blood glucose monitoring may improve glycemic controls, can enhance patient engagement and self-management, will personalize treatment adjustments, improves quality of life, and data-driven decision-making does give us comprehensive data and enhances our communication with our patients and reduces healthcare costs fewer hospitalizations, and efficient resource utilization. Overall, far more effective and efficient diabetes management. Thank you.
My presentation is going to be the impact of lifestyle, diet, and development of diabetes. The topic of my presentation is the impact of lifestyle, diet, and stress on the occurrence and development of diabetes. And of course, I declare that I have no actual conflict of interest in relation to this presentation. We all know that we are facing global pandemic of diabetes mellitus, and that 1 in 10 adults around the world are currently living with diabetes. The total number is predicted to rise to 643 million by 2030 and to 783 million by 2045. If we know that almost 50% of adults are living with diabetes and are undiagnosed, it leads us to a number of 1 million or 1 billion, in fact, of people living with diabetes in only 20 years ahead. Mortality risk from diabetes is also very high, and 6.7 million adults are estimated to have died due to diabetes or its complications in 2021, which means that 1 in 10 of global deaths from all causes is in fact diabetes. So these numbers are really very frightening, and we are really fighting global pandemic, and we have to do everything what is in our power to try to stop this pandemic. Recommendations about treatment of diabetes have been changing a lot, and in the last few years, we have a specific holistic person-centered approach to type 2 diabetes management, which put the patients in the center of our care. Prevent complications and optimize quality of life are our main goals, and it can be done not only by glycemic management, but also by weight management, by risk factor management, cardiovascular risk factor management, and of course, use of new cardiorenal protection therapies. But holistic person-centered approach is something that is nowadays cornerstone of modern diabetology. Can healthy lifestyle and diet prevent diabetes? What do our organization say? World Health Organization last year says that a healthy diet, regular physical activity, and maintaining a normal body weight and avoiding of tobacco are ways to prevent or to delay the onset of type 2 diabetes. We of course know that we can't fight and that we can't have influence on some genetic factors, but healthy lifestyle can delay the onset of type 2 diabetes, and diabetes can be treated by diet, physical activity, and medication in order to prevent or delay the onset of complications. What does ADA, American Diabetes Association, say? In 2024, ADA says that we have to refer all adults who are overweight or obese and have a high risk of type 2 diabetes to an intensive lifestyle behavior change program to achieve and maintain a weight reduction of at least 7%. A variety of eating patterns can be considered to prevent type 2 diabetes, and it's very important to know that these diabetes prevention programs should be covered by third-party payers, and of course based on individual preference. Certified technology-assisted diabetes prevention programs may be effective in preventing type 2 diabetes. American Heart Association also says that lifestyle changes such as losing weight, eating healthy, and regular physical activity may reduce the progression of prediabetes and help control diabetes, and not only control diabetes, but control other risk factors such as high blood pressure, blood cholesterol, and even heart attacks and strokes are much less to happen. But of course, we know that we all live in an era of evidence-based medicine, and we do have to take into account the results from our randomized studies. And what do randomized studies say? Diabetes Prevention Program Study, the Finnish Diabetes Prevention Study, and the King Diabetes Prevention Study all have the same conclusion that healthy lifestyle intervention is highly effective in preventing or delaying type 2 diabetes. Diabetes prevention program study is a cornerstone of these prevention programs and studies, and it says that almost 58% of diabetes can be in fact prevented by healthy lifestyle. Healthy lifestyle behavior intervention is highly effective in preventing, and not only preventing, in delaying type 2 diabetes as well. How important is nutrition? There is no ideal percentage of calories from carbs, from protein, fat, and we have different preferred diets. We have Mediterranean diet, we have low carb diet, we have vegetarian diet, we have DASH diet. They all, in fact, have the same impact on delay of diabetes. But what we have to bear in mind all the time that only individualized approach when we talk about nutrition is something that is very effective. We maybe prefer Mediterranean diet or Med diet, but Med diet is not only a diet, it's also it became a way of life. What does Mediterranean diet or Med diet comprise of? Physical activity, enjoy daily whole grains, lots of fruits, a lot of vegetables, healthy fat, moderate consumption of dairy products and wine, and low intake of red and processed meat and foods that contain high amount of added sugar. Med diet has proven effect in randomized trial as well, and PREDIMED, the primary prevention of cardiovascular disease with the Mediterranean diet study, in fact showed that the risk of developing type 2 diabetes was reduced by 52% in patients who had no diabetes at the beginning of the study and who went on Med diet. Med diet also decreases the cardiovascular risk, decreases the proatherogenic genes expression, decreases waist to hip ratio, decreases lipoprotein particles, diminish oxidative stress, and decrease markers of inflammation. A Med diet, in the very base of this Med diet pyramid, is not nutrition only. As I said, it's a way of life. So regular physical activity, socializing, and sharing mealtime with others and meeting with friends is something that lies in the very basis of this pyramid. And of course, daily habit with eating a lot of vegetables, a lot of fruits, frequently eating of fermented daily products, fish and seafood is something what this Med diet pyramid is in fact consists of. Med diet has beneficial effect on insulin resistance, and it's proven. We know that insulin resistance is one of the main pathophysiological mechanism in the onset in the pathophysiology of diabetes, and it has been proven that Mediterranean diet can improve insulin sensitivity through different mechanisms and in fact reduce insulin resistance that lies in the very middle of diabetes. And as a conclusion, Med diet can be used in diabetes prevention. It surely decreases HbA1c, decreases the risk of cardiovascular diseases, improves diabetic dyslipidemia, improves weight loss, decreases the risk of cancer and risk of depression. But we have to bear in mind that no superiority compared to other diets in clinical studies. So Med diet has the same effect as all other diets, and in clinical studies, we have the same results. What about nutrition recommendations for people with diabetes who are obese and who are overweight? Weight management should represent a primary goal as well as glycemic management. So if we have a patient with diabetes who is obese or overweight, we have to take into consideration weight management as well and along with glycemic management. And something what we aim for is a weight loss of 3 to 7%. minimum, and that weight loss, in fact, improves glycemia and other cardiovascular risk factor. If we have a weight loss of more than 10% of body weight, then we can talk about possible remission of type 2 diabetes and disease-modifying effects. When we talk about remission of type 2 diabetes, it's something rather new, and we say that remission is in fact normal value of HbA1c in patients with no anti-diabetic treatment for more than 6 months. So if we achieve body weight on a loss of more than 10% of body weight, then we can consider disease-modifying effect and possible remission of type 2. Nutrition and physical activity and behavioral therapy in order to achieve a loss of more than 5% are recommended for people with type 2 diabetes. And when we talk about nutrition, these recommendations should be individualized, and that's, as I said previously, is a cornerstone of modern diabetology today. And each therapy, including nutrition, must be tailored to each patient. But what we have to bear in mind that we have to have energy deficit between 500 and 750 kilocalories per day in order to achieve weight loss. What about supplements? Very often patients are asking whether they have to take some supplements or not. About nutritional supplements, they have not been shown to be effective for weight loss, and they are not recommended for weight loss. But when we talk about patients with diabetes, they may be indicated if we can prove and document deficiency. So we have to measure iron, we have to measure vitamin B12, we have to measure vitamin D, and if we have any kind of deficiency, then supplementation is necessary. Medical nutrition therapy is the treatment of a disease, in our case of diabetes or any other condition, through the modification of nutrient or whole food intake. So we have medical nutrition therapy, or MNT, very essential in diabetes management. And as I said, for nutrition, one size fits all eating plan is no longer valid, and the therapy and medical nutrition therapy should be individualized. And of course, the need for MNT should be reassessed frequently, because during the lifespan of patients with diabetes, we have different demands regarding medical nutrition therapy. What are new recommendations for MNT? First, we have to refer all adults, no matter whether type 1 or type 2 diabetes, to diabetes-focused MNT at diagnosis and later throughout the lifespan and during times of changing health status. Diabetes MNT must be provided by a registered dietitian or a registered nutritionist. MNT in diabetes has its effect and has its goals, and the goal in patients with type 2 diabetes is to decrease HbA1c from 0.3 to 2%. MNT in diabetes also have to promote and support healthy eating patterns in our patients with diabetes. It has to address individual nutritional needs to maintain the pleasure of eating. Before, as I said, good quality of life is something that comprises pleasure of eating as well, and to provide an individual with diabetes the practical tools for developing healthy eating patterns. When we talk about weight management in patients with diabetes, we said that weight loss of minimum 5% or higher is needed to reduce the risk of progression of prediabetes to type 2. And also, this percentage of weight loss is necessary if we want to have beneficial outcomes in glycemic control, in lipid control, and BP control. Of course, long-term durability of weight loss remains a challenge, but nowadays we have new options, new drugs that in fact can cause weight reduction up to 20%, and they have sustainable CV outcomes. Physical activity is another step in healthy behavior, and we always have to bear in mind that physical activity is as important as nutrition, as important as therapy, and moderate intensity physical activity has shown beneficial effects in those with prediabetes and prevents progression to diabetes. Physical activity is proven to improve the insulin sensitivity and can be beneficial in the prevention of gestational diabetes. What are the ADA recommendations in the ADA standards of care from this year? It said that patients with type 2 diabetes must be engaged in 150 minutes or more of moderate to vigorous intensity activity, physical activity per week, spread over at least 3 times a week, with no more than 2 consecutive days without activity. 150 minutes per week, at least 3 days a week, and no more than 2 consecutive days without activity. What are other recommendations? For all people with diabetes, we have to evaluate baseline physical activity and time spent in sedentary behavior. We know that baseline physical activity differs among the patients, and we have to bear in mind that physical activity has been tailored to each patient itself. For people who do not meet activity guidelines, we have to encourage them to increase their physical activities and always counsel that prolonged sitting should be interrupted every 30 minutes in order to achieve better blood glucose. When we talk about intensity of physical activity, we had some old parameters, and we know that maximal heart rate was very long used as a key unit for describing intensity of physical activity, and we could easily calculate maximum heart rate by simple formula 220 minus age. But now, and in order to achieve this maximum heart rate, we could, in fact, we could divide physical activity in moderate and vigorous exercise intensity. But nowadays we have a new physical activity intensity units, and that new unit is called MET. MET stands for its metabolic equivalent. In fact, it's the amount of energy, or in fact, energy expenditure during rest, and 1 MET means that a person consumes 3.5 milliliter of oxygen per minute per kilo. MET, as I said, is a new activity, physical activity intensity unit, and by counting these METs, we can divide physical activity in light, moderate, vigorous. Light physical activity with less than 3 METs. We can see that, for example, sweeping floors, cooking, bathing, or walking 2 miles per hour, in fact, are these low activities. Moderate physical activities with 3 to 6 METs. We have moderate activities like walking the dog, food shopping, walking 3 miles per hour, and vigorous activity with more than 6 METs like jogging, running, swimming, and etc. So nowadays we use this new physical activity intensity units, and when we talk about physical activity, we are trying to educate our patients about MET. Of course, when we talk about physical activity, we have to have individualized approach as well. And if we talk about 150 minutes, what is an average recommendation of physical activity per week, then we talk about 500 to 1,000 METs per minute per week. As I said, physical activity is very important, and high frequency of regular leisure time physical activity was more effective in reducing HbA1c level. As you see on this slide, it's also in standards of care of American Diabetes Association from this year, a wide range of activities, including yoga, swimming, tai chi, and other types of physical activities, are shown to have significant impacts on metabolic control, on reducing A1C, on better flexibility, on improving muscle strength, and decreasing sarcopenia. They have a very good effect on balance as well. very often our patients are asking whether aerobic physical activity or resistance physical activity, what is better? Resistance training has added effect in lowering HbA1c, and people with type 2 diabetes should be encouraged to do at least 2 weekly sessions of resistance exercise. When we talk about resistance exercise, we talk about free weights, machines, elastic bands. It all depends, of course, on the patient, but these resistance exercise should be combined with aerobic ones. In the end, stress, we know that stress increases the risk of diabetes through different mechanisms. First of all, through neuroendocrine pathways by increased cortisol, which leads to hepatic gluconeogenesis, to increased levels of lipids, direct effects on beta cell, and etc. Stress also provokes and inflammatory processes. So stress can be the trigger and can increase the risk of diabetes. On the other hand, diabetes is a cause of stress as well. Stress at the time of diagnosis of diabetes is something that we are maybe not so much aware, because at the time of diagnosis, psychological backup is really needed. And I think that we are not doing well in this area, and we are not bringing our patient the adequate psychological backup. Of course, stress caused by dealing with daily diabetes care is something that is very common, and people with diabetes often feel discouraged, worried, frustrated, or tired. Diabetes distress is something that has been recognized in the past few years. It's very common. It shares some features with depression, but of course it's not depression, but it has unique relationships with glycemic and other outcomes. The prevalence of diabetes distress among patients with type 2 diabetes is almost up to 50%. And that constant demand on diabetes self-management, they have to think about dosing of medication, dosing of insulin, frequency, titration. They have to monitor their blood glucose level. They have to take care about their food intake, about their eating patterns, about physical activity. All these demands, in fact, are parts of diabetes distress syndrome, and the potential of disease progression are directly associated with diabetes distress. Do we think about it? Only 1/4 of patients report that they have been asked about how diabetes affected their lives. I think that we have to be more proactive. We have to ask our patients about diabetes distress, and of course, to refer them to special psychological backup if it's needed. Diabetes distress can be monitored using some validated measures, and we have different questionnaires about hypoglycemia, PAID scale, and etc. But I'm not sure that we are using them as much as we should. A part of diabetes distress is hypoanxiety and fear of hypoglycemia. We have to educate our patients about hypoglycemia. Maybe hypoanxiety is something that we most often encounter with our patients with type 2 diabetes. We have to teach them how to handle hypos. We have to teach them how to manage their blood sugar levels. They have to encourage them to talk to us or nurses about hypos. They have to encourage them to talk with other people with diabetes about these problems, and of course, if necessary, to refer them to cognitive behavioral therapy. How to cope with stress? It's not easy at all. Stress management is something that we are facing in our everyday life, no matter whether we have diabetes or not. But stress management in patients with diabetes is somehow different. They have to maybe to put more efforts and to think more about exercise and healthy diet, and it's a very good way to try to cope with stress. Listen to the music, following different hobbies, meditation, yoga, laughing, enjoying, going to the nature, socializing. All these are simple techniques in order to manage the stress. And how to cope with diabetes distress? First of all, education And that is the core of everything, because if they have no fear, if they know how to cope with their disease, it will be much easier. Of course, we always have psychological therapies such as cognitive behavioral therapy and mindfulness-based therapies and health behavior change approaches such as motivation, interviewing, and etc. We have to support positive health behaviors. We have to improve and to implement behavioral strategies to support diabetes self-management and engagement in health behaviors. Taking medications, using diabetes technologies, engaging in physical activity are all, in fact, tools to promote optimal diabetes health outcomes. We don't have to forget about sleep. Sleep is very important. Sleep disorders are a risk factor for developing diabetes, among, of course, other risk factors. But on the other side, patients with diabetes have sleep disruptions and reduced sleep quality of various type. Almost 1/3 to 86% patients with type 2 have obstructive sleep apnea, and nearly 40% of patients with type 2 have insomnia. So sleep health also has impact on metabolic control of diabetes. We all know that shift work increases the risk for circadian rhythm disorders, which are associated with higher A1C and worsening of complications, especially neuropathy. We have a higher incidence of depression. So the sleep health is something that really matters. And take-home messages, I think that I've tried, in fact, to tell you that we have to take into consideration that healthy lifestyle is very important. Healthy diet, regular physical activity, maintaining healthy lifestyle and normal body weight can prevent diabetes. Constant education is needed regarding healthy diet and is necessary in patients with diabetes throughout their lifespan. We have to insist on regular physical activity in patients with diabetes, and we have to take care of psychosocial status of our patients and help them to cope with the stress. Thank you very much. Great honor to present Professor Gül Yeşiltepe Mutlu. She's professor of pediatric endocrinology from Koç University School of Medicine, Istanbul, Turkey. And she's going to give us a talk on metabolic targets and 10 key factors in children with type 1 diabetes.
Hello everyone, my name is Gül Yeşiltepe Mutlu. I'm a pediatric endocrinologist. We have prepared this presentation with Professor Şükrü Hatun. We both work in Department of Pediatric Endocrinology and Diabetes in Koç University School of Medicine in Istanbul, Turkey. And today I will talk about metabolic targets and also 10 key factors for children with diabetes. And before starting, I'd like to thank all the organization committee for this very nice and very available meeting. So I have nothing to declare. And here is my layout. I will talk about the current challenges and also needs in the management of type 1 diabetes, and also the global and Turkish context of type 1 management. And lastly, the targets and 10 key factors in the management of type 1 diabetes among children, which we believe critical for the achieving the glycemic outcomes. And we believe that it can be helpful for your clinical practice as well. So as you know, there are lots of numbers for the metabolic controls for hemoglobin A1C levels or according to the different guidelines. And also nowadays, there are many new terminology, many new terms like time in range or coefficient of variation or some other metrics from the sensor downloads. However, it's not the managing type 1 diabetes is not just about controlling the blood glucose levels and just not the numbers. It's about improving a child's quality of life. And the main goals are preventing acute and long-term complications, preventing severe hypoglycemia and decreasing mild hypoglycemia as well, and also avoiding the fear of hypoglycemia, and facilitating the post-meal glucose management or preventing post-meal excursions. For all of these aims, we need to support our children with diabetes, both in school and also at home. And other factor is the weight control is another important thing, but at the same time, we need to prevent eating disorders and also recognize it early in the clinics, especially among the adolescents with type 1 diabetes. This slide is showing the distribution of glycemic outcomes based on the last hemoglobin A1C levels among children with diabetes in Turkey. You see that a very important proportion of the children with diabetes in Turkey have poor metabolic control with an hemoglobin A1C level of above 9%. So this data highlights us. We need a more enhanced education for children with diabetes and a better adherence to treatment plans and using technology and more effective management strategies to improve the metabolic outcomes. And this table, this slide is from the long-term data on hemoglobin A1C levels in the Swedish pediatric population with type 1 diabetes from 2000 to 2020. It is provided by the Swedish National Diabetes Registry. And as you see here, almost 80% of the children have a good metabolic control with an A1C level of below 7.3, and only 4.5% have a poor metabolic control. So it shows us it's possible to succeed a good metabolic control in children with diabetes, and this table gives us hope. And this is from our own center, Koç University Pediatric Diabetes Center from 2022. As you see here, the median hemoglobin A1C level is 7.1 in children which we care. And it's clearly seen that the technology use improves metabolic control. For example, here you see that the AID or automated insulin users, delivery users have a mean hemoglobin A1C level of 6.8. So we can say that we think that comprehensive training, teamwork, and 10 basic recommendations and the use of technology are very effective in achieving glycemic targets. What about the complications? How close or how far away are the complications and when to start screening? This study shows, this is an epidemiological analysis, and over 25 years, the microvascular complications are rising at an average A1C level of 7.6%. And the most important thing is that if you have a good metabolic control, especially in the first 2.5 years on the of the diagnosis, this has a more significant effect on the preventing complications. Therefore, it's important to strive for strict goals immediately after the diagnosis is very, very important, and good metabolic heritage is a good factor for preventing the complications. So we start the screening for complications 5 years after the diagnosis or after the age of 11, which is parallel with ISPAT guidelines. And we always remind our patients and their parents especially, not to threaten their children with diabetes, with kidney damage or blindness, because we know that it will create hopelessness in the children. And this data is from the children, normal, healthy children who are non-diabetic, with CGM, Dexcom, G6 values. So this is a very good reference point for normal glucose levels. And you see here, time above 140 milligram deciliter is very limited. It's just 1.3%. And time above 120 is also minimal. So the closer we get to these levels, these values, the more successful we are. So it's time to tighten the targets and use time in targets or time in tight range, which is defined as the time between 70 and 140 milligram per deciliter alongside time in range. The International consensus recommends at least 70% for time in range, which is defined as between 70 and 180 milligram per deciliter, while the latest international consensus recommends at least 50% for time in tight range, described as the time spent between 70 and 140 milligram per deciliter. So after having talked about metabolic controls, we see that many of the children with type 1 diabetes cannot achieve these metabolic control goals. So what are the reasons for this? For example, the lack of residual beta cell function or lack of physiological insulin treatment, but also the burnout and overburdening the families is another factor for not achieving these goals. And also out-of-date practices, for example, going to bed with high glucose levels at night with the fear of hypoglycemia, or 3 mandatory snacks in addition to 3 main meals may cause hyperglycemia, and technology access challenges and inequities accessing the technology, the other factors. Inertia is a very important factor because both patients with diabetes and also the members of diabetes teams can fall into it, where they stick to outdated practices. And we know that all of these may cause hyperglycemia, poor metabolic control, and also a burnout situation. So what can we do? We suggest an approach which should be individualized for each child, for each kid with type 1 diabetes. And we give an individual diabetes management plan to all of the children who are followed in our center. And this is a sample of it. Sorry, that's in Turkish. But in this individual plan, we give lots of details, especially the basic principles of the managing diabetes, and also the amount of carbs per meals and insulin carb ratios or insulin sensitivity factors, and also how to manage hypoglycemia, how to measure blood or urine ketone levels as well, and etc. Our recommendations are based on the literature, scientific guidelines, especially ISPAT guidelines, and we are in contact with outstanding international pediatric diabetes center, and we are thankful to them for sharing their all experiences with us. So now let's move on to basic recommendations and key factors, and let's go in every factors in details. So the first rule is giving fast-acting insulin injections or boluses before the meals. It's usually based on the bolus timing is based on the pre-meal glucose levels, as you see in this table. And we teach our patients to delete the last digit of blood glucose value to calculate how many minutes they will need to wait. For example, if their blood glucose level is 150 before the meal, they need to wait for 15 minutes before eating after insulin injection. This rule is very important, especially for the breakfast times, because we all know that there is an insulin resistance at the time of breakfast, especially in the early time of the day. But it's also important for the other meal time as well. In this era, many people with type 1 diabetes use insulin pumps, but an important amount of them are still on multiple dose insulin injection therapy, especially in Turkey. And lipohypertrophy is still a frequent and important problem, especially in the people who are on MDI. And in our country, the habit of injecting insulin to the lower part of the abdomen and also on both sides of the navel is very common. And we recommend them to use the entire abdomen area for insulin injections. And also, the insulin injection sites are important for the optimal absorption. For example, for the fast-acting insulins, we recommend to use abdomen and also the arms, which are the fast-acting or fast absorption areas for the insulin. However, the long-acting insulin, like glargine or detamine insulin, we recommend to use the buttocks and also thighs, where the insulin injections, insulin absorptions are slower than the other parts. And also it's good to remind all members of the pediatric diabetes teams to check insulin injection sites in every visit to recognize lipohypertrophy and preventing it. The second rule is going to bed with a normal glucose levels, because fear of hypoglycemia often leads people with diabetes to consume unnecessary carbohydrates and to go to bed with a high glucose levels, because people think that if they have a high blood glucose levels before going to bed, they will be protected from night hypoglycemia. But it's a more accurate approach to enter the night with normal glucose levels. And the studies show that above 100 milligrams per deciliter before sleep is safe for children to prevent hypoglycemia in the night. And also, the latest ISPED guidelines recommend that a glucose level prior to bed is enough if it's above 70 milligrams per deciliter. And the third one is avoiding snacks unless necessary, because we know that snacks eaten without bolus insulin cause deterioration in the blood glucose profile and causes high blood glucose levels. But also they improve the diet quality and glycemic results as well. So in our clinic, we recommend the children with diabetes avoid snacks unless they have hypoglycemia or they had exercise. And in these cases, they can take snacks without insulin injections. But if they are so hungry and they need snacks, they can take it with insulin injections as well. The fourth one is the early and careful carb counting. It's very important to introduce carbohydrate counting at the beginning of the diagnosis, because we know that carbohydrate counting allows for more flexible nutrition, diets, and also more flexible life. And also it helps understand the mathematical basis for insulin dose calculation. We know that it's sometimes a challenge for the people, especially at the beginning of the diagnosis. But nowadays, there are lots of applications, there are lots of apps for learning carbohydrate counting. We have our own carbohydrate bolus calculator apps. This is the first page of this application. And it was created by one of our students with type 1 diabetes and also our dietitian. And we see that it's really helpful to the people in terms of learning carbohydrate counting and also calculating the doses for the meals. So what is the optimal amount of carbs for best insulin carb matching per meal? This is a debatable topic, but one study from Australia, our colleagues showed that the optimal amount for carbs is around 50 to 60 grams per meal. Because if the people have more than 60 grams of carbs at a meal, it can make it difficult to match the carbohydrates and also insulin doses. So if you increase the insulin dose to achieve a good effect, we know that there is a risk of hypoglycemia before the next meal. If you have a pump, you can give a dual bolus with this, and you can prevent hypoglycemia and also prevent post-meal hyperglycemia as well. So another factor is handling the phenomenon of reverse down. People usually know the down phenomenon, but there is also reverse down, and it's characterized by hyperglycemia, especially among young children, because we know that they often experience elevated glucose levels, especially between 9 p.m. and midnight. And it is thought that this is related growth hormone secretion in the earlier phase of sleep. And because of growth hormone secretion, the glucose levels rises. And if you give an unnecessary snack or milk feed before bedtime with the fear of hypoglycemia, it may exaggerate this phenomenon and cause higher glucose levels during the entire night. So it may be advantageous to consider shifting this milk consumption in the earlier times of the day to avoiding hyperglycemia in the midnight. And of course, using technology, especially sensors, but also automated insulin delivery systems as soon as possible after diagnosis. It improves metabolic control, we know. So insulin pump therapy should be presented as an option, but in Turkey, the insulin pumps are not covered by the government. So we present it as an option, but we always prioritize the sensors in the beginning of the diagnosis, from the first day of the diagnosis. And this table, this figure is from a study which was conducted by Barbara Dev's Diabetes Center. Our colleagues showed that in the study, if the people start to use sensors from the beginning of the diagnosis, they have better glucose controls and lower hemoglobin A1C levels throughout the 7 years in the follow-up period. So we should strive for equitable access to diabetes technologies, especially for the children with diabetes. And continuous communication and support should be provided to technology users by team members and also technology companies as well. And the next one is the early corrections with small doses of insulin. It improves time and range and enhances insulin sensitivity. And it's advisable to initiate corrections early and with smaller doses. If we do that, we have an opportunity to reduce the risk of hypoglycemia due to larger corrective doses. While doing this, we usually aim a glucose range between 100 and 120 milligram per deciliter. Of course, it can be individualized. If blood glucose exceeds 145, this is our recommendation in our clinic, we recommend our patients to do correction doses if their insulin sensitivity or insulin correction factor allows us. And if they are on sensors, if they use sensors, it's good to take the sensor errors into consideration to make a precise calculation for correction doses. And the next one is avoiding or limiting problematic foods such as pizza or burgers, because we know that high-fat meals cause late postprandial hyperglycemia. And even with AID systems, it may be difficult to manage this hyperglycemia for long hours. Fats delay the postprandial rise time of glucose because they delay the gastric emptying time and also decreases insulin sensitivity. If they are on MDI, we advise to increase the dose of bolus insulin up to 30% if they have a fat-rich meal and give this extra dose 1 hour later. And also checking their postprandial glucose levels, not only at the 2nd hour, but also 3rd, even at the 4th hour. If they are on pump, dual boluses in pump therapy favorably influence the glycemic course, and a good we can obtain a good metabolic control after meals. But at least 60% of the calculated bolus should be given 15 minutes before the meal. Fats causes insulin resistance, and even in the children who are on low-carb diets, especially in adolescents, we also see this insulin resistance and high glucose levels sometimes because they usually take more fats and protein instead of carbs in these diets. And the last two factors are incorporating exercise into daily routine and to continue diabetes treatment according to the principle of doing our best, but without turning it into a stress, and live with diabetes in a peaceful or in a friendly way. So last year, we published our opinions and recommendations for the management of type 1 diabetes, and we translated the book by Professor Ragnar Hanas into Turkish for all children with diabetes and their families. While I am closing, I'd like to thank all of my friends in my home center team, and also to everyone who improves the lives of children with diabetes and who works for this. Thank you for attention.
Our next speaker is Dr. Daniel-Tudor Cosma, resident in diabetes, nutrition, and metabolic diseases from Center for Diabetes, Nutrition, and Metabolic Diseases at County Clinical Emergency Hospital in Cluj-Napoca. And he's going to give us a talk on insulin overdoses between fast recognition, intensive monitoring, and proper treatment.
Good afternoon, everyone. My name is Daniel Cosma. I'm from Horezu City Hospital, Vâlcea County, Romania. And today I will try to give you some hints about insulin overdoses between fast recognition, intensive monitoring, and proper treatment. These are my conflict of interest and my disclaimer. And as you can all know, insulin is a hormone with two edges. If it's too much, it can kill you. If there is a deficiency, it can prolong or give you life, like in cases of patients with type 1 or type 2 diabetes. When we speak about insulin overdoses, you must know that the first insulin overdose was actually therapeutic and was used to treat schizophrenia. It was so-called insulin shock therapy, and this therapy revealed some of the insulin complication. But actually, the first insulin murder was documented in 1957. It was the Kenneth Barlow who murdered his wife, but he was discovered and punished. The largest insulin overdose was almost 60,000 international units, a mix of human insulin, humulin R, and humulin N. And the first insulin analog overdose was reported in 2004. Let's see what is a significant suicidal insulin overdose. In people without diabetes, administration of more than 100 international units of insulin is considered a suicidal overdose. In people with diabetes, twice the total daily dose in patients treated with insulin is also considered a suicidal overdose. Usually, there are also other drugs that are administered with insulin, especially as you can see in this illustration: benzodiazepine, alcohol, antihypertensive medication, other oral antihyperglycemic agents, opioid, and so on. Regarding the group of age that is most affected by insulin overdose, as you can see, it's a bell-shaped form. The person between 30 and 40 years of age reported more this insulin overdose, followed by those with 40 to 50 years of age. Let's see what are the who are prone to this insulin overdose. Usually, people with all kind of psychiatric problems like depression or anxiety and so on, relatives or friends of people with diabetes who have access to insulin, also healthcare providers, nurses, pharmacists, doctors, and let's not forget bodybuilders who use insulin like an anabolic agent in order to promote muscle growth. It's very, very important to recognize an insulin overdose because it can lead to a cerebral defect in 2.7% of cases, or death, the same percentage, but most of them, almost 95% of them, get full recover. It is very important to note that mortality can reach to 25% in the case of co-ingestions. Co-ingestion of other substances like sedatives or beta blockers may mask the symptoms of hypoglycemia and may delay the treatment. It is very important to know that the presentation is polymorphic. It can be symptomatic hypoglycemia or people who is brought to the emergency department in coma. And it's very important that late presentation to the hospital and delaying the intravenous treatment for more than 6 hours, it's an independent predictor of death. In a patient with a history of depression, a patient who was brought to the emergency department with hypoglycemia, unresponsive or minimally responsive to glucose infusion, with significant elevated plasma insulin level, but with low or normal C-peptide level. If the person has positive insulin antibodies, if the patient has multiple injection sites or huge injection sites on the abdomen of thighs, which is reveal of insulin administration, or especially in children, if they have access to insulin and they present acute transient hepatomegaly, we must think about an insulin overdose. It is very important to be very careful and to monitor renal function, electrolytes, magnesium, phosphate, liver function, coagulation, and if it's possible, serum insulin level. The aim of the treatment is to avoid hypoglycemia. It is very, very important to avoid or treat complications due to overdoses or to avoid iatrogenic complications. This is a nice table that summarizes the treatment with glucose or dextrose infusion. It is very important to maintain a state of euglycemia, and if the patient is prone or in hypoglycemia, we can increase the infusion rate by 25 or 50 milliliters per hour. We can give intravenous glucose stat, and we have to intensify monitoring every 15 minutes. If the blood sugar level are between 72 and 162, we can continue the current infusion rate, and the monitoring will be every hour. If we have higher values of blood sugar above 162, we can decrease the rate, and we can consider that the effect of insulin will disappear, but we have to be very careful and to monitor every 30 minutes. In large hospitals, it is possible to monitor insulin level, and this is very important because it can help us guide the treatment. We can make, as you can see, switching from different glucose or dextrose concentration. As you can see in this figure, it can help us in stopping the infusion. It is recommended that when the insulin level reaches or is near 100 picomoles per liter, we can stop the infusion of glucose or dextrose. Why it is so important to monitor the insulin levels? Because there are so many factors that influence the insulin absorption. There are factors related to insulin, as you can see: physical state of insulin, the volume injected, the insulin concentration, related to the injection size, the number of the injection site, the presence of lipo hypertrophy, possible degradation at the injection site. And I want to remind you about the Toujours insulin, that a part of it is degraded at the injection site, and local blood flow at the injection site. Also, we have factors related to body, like hepatic or renal dysfunction, or the presence of antibodies against insulin. Besides glucose or dextrose, we can use glucagon to treat, and it's very important because it reduces the amount of glucose that needed to be infused, and also it helps us to avoid lungs or liver damages. We will see this complication. The main disadvantage is that in people who injected long-acting insulin analogs, the possibility of rebound hypoglycemia is present. We have to be very careful because we know that glucagon is an arrhythmogenic agent, especially in patients who are known with all kinds of cardiac problems. And also the rapid administration can lead to gastrointestinal problems like nausea or vomiting. And we can use in these cases mini doses of glucagon. It's very important to know that this is not affected in people with malnutrition, with liver diseases, with the patient on low carbohydrate or keto diet. And now we have also the possibility of administered glucagon by intranasal doses. It's the Baqsimi. This is the only form that it's available in our country, in Romania. Another possibility of treatment is using octreotide that binds to the somatostatin receptor type 2 located on pancreatic beta cell and blocking the insulin release. This is especially effective in overdoses with sulfonylurea or in overdoses with sulfonylurea and insulin. It's very important to note that this is not effective in people with type 1 diabetes, only in non-diabetic patients or those with type 2 diabetes. And higher doses may inhibit the insulin clearance and may favor hypoglycemia. So very careful with high doses of octreotide. Another possibility, and this is a wonderful figure made by our colleagues from intensive care units. If we have a huge amount of dextrose who is administered IV, we can start hydrocortisone 100 milligrams initially intravenously and then repeat it every 6 hours. We need to decrease the concentration of dextrose or to decrease the rate around 100 milliliter per hour, but we don't need to stop it. Then we can accept in these cases moderate levels of hyperglycemia with glucose values around 125 to 150 milligrams per deciliter. And it's very important to encourage the patient to resume oral feeding, or if the patient is unconscious, to initiate feeding on enteral tube in order to decrease the level of glucose or dextrose that needs to be infused. This is a very nice table that summarizes all the slides that I show you. And also, as you can see, we have a section designated to pediatric doses for all of this. And it's a free article which is available online. Another possibility, apart from the medical treatment, is the excision of the injection site. As you can see in this figure, the excision of the injection site was made almost 5 hours after admission in the emergency department. As you can see, the excision of the injection site led to the significant decrease of the insulin infusion, and also helped the patients with a very good obtaining a very good blood glucose values and avoiding hypoglycemia, and also help the patient to be discharged faster. This excision of the injection sites can be done if there are a limited number, 2 or 3. But if the patient injected the insulin in multiple areas around the abdomen of the thighs, this surgical procedure is not recommended. Another possibility which was used for treating insulin overdose was utilization of artificial pancreas. This is an interesting article from Japan, where they use an artificial pancreas called STG55, which is used in this country especially for maintaining very good blood glucose level for people with massive surgery like liver or gastric or esophageal surgery. As you can see, the use of this pancreas never resulted in hypo or hyperglycemia, and the patient can be discharged earlier. Regarding the complication of insulin overdose, there are, as you can see, permanent cognitive dysfunction due to the hypoglycemic encephalopathy, acute hepatic steatosis, pulmonary edema, electrolyte disturbances, or death. And when we are speaking about electrolyte, we must be very careful with potassium, magnesium, and phosphate. Regarding potassium, as you can see, the low levels are due to intracellular shifting, can lead to cardiac arrhythmias. We need to monitor the potassium level every 12 to 24 hours, and also we can monitor the AKG if we observe low values. IV potassium chloride is used. For hypomagnesemia, it is due to intramuscular shift, prone the patient to cardiac arrhythmia, and also very important that the low magnesium level potentiate the arrhythmic effect of low potassium. The same monitoring every 12 to 24 hours and also on EKG, and the treatment is with IV magnesium sulfate. For a low phosphate level, it is due to muscle uptake. It decreased the threshold for ventricular arrhythmia, and also very, very important that the low phosphate level can aggravate the cerebral damage induced by hypoglycemia, and it can be corrected by administering sodium phosphate. Regarding acute pulmonary edema, as you can see in this figure, this it's in the first day of admission. This is the 4th day from admission. The pulmonary edema can be caused by a neural mechanism due to the severe brain injury that was produced by severe hypoglycemia, but also this pulmonary edema can be caused by a disturbance in the alveolar permeability. It is very, very important to monitor the patient, especially those with large doses of insulin. Another complication is an increasing of liver enzyme after administration of large doses of insulin. As you can see, values above 1000 that decrease after normalization of the glycemic value and after proper treatment. And as you can see on the CT scan, we have the typical aspect of hepatic steatosis, and the liver biopsy reveal that hepatocytes are with large amount of fat. Actually, we will see that is not fat, it's glycogen, and this is a CT that was repeated before discharging the patient, and you can see on liver biopsy almost resuming the pathological aspect. And as you can see, the insulin stimulates the glycosynthesis in the hepatocytes and leads to the accumulation and balloonization of the cell, which resembles fatty accumulation, but actually it's a glycogen storage hepatomegaly, which is usually transient, and this was especially described in Asian population and especially in kids. These slides, it's resume the cases that I've treated during my residency program. And the last one, the 5th case, was treated in this small city hospital. As you can see, the largest overdose was with Humalog mix 50. It was 22.5 international units per kilogram body per day. The patient administered 1,500 international units. As you can see, only one case was co-ingested with diazepam and acetaminophen. All of them had psychiatric disorders. All of them had depression and other emotional unstable personality disorder. 2 of them decided to inject insulin after a conflict in the family with the wife or the boyfriend, and 2 of the cases had previous attempt. The second patient had 2 previous attempts. So very, very careful, because this patient follows the typically characterization of people having access to insulin, usually after a conflict in family, and they have a history of psychiatric disorder. In conclusion, there is no randomized control trial to guide treatment of insulin overdoses. Indeed, treatment with glucose or dextrose infusion, sometimes supplemented with glucagon, is almost always effective in restoring euglycemia, but we don't know what is the proper treatment to restore cerebral function. Insulin overdose definitely required intensive and prolonged glycemic monitoring to prevent recurrent hypoglycemia due to an early cessation of intravenous therapy. And the dose is not correlated with the severity of hypoglycemia, but with a prolonged hypoglycemic risk higher than that deduced from the pharmacokinetics of insulin administered. I want to thank you for your attention, and this is the bibliography that I used for this presentation. Thank you so much. And if you have questions, I will gladly answer it.
And at last but not the least, Dr. Maria Bojagieva. She's the head of diagnostic and consultative department at University Hospital of Endocrinology, and she's chief assistant professor at Medical University Sofia, Bulgaria. And she's going to give us a talk on gestational diabetes, risk factors, regular screening, and adequate behavior.
Hello, dear colleagues. My name is Dr. Maria Bojagieva, and I'm really happy to be part of this symposium and to share my knowledge regarding the gestational diabetes. I declare that I have no actual or potential conflict of interest, and all the view, opinions, and information expressed in the presentation are my own. As you can see from the history of diabetes, we all know that it has started a long time ago, and gestational diabetes has chosen its place through the classification of diabetes. It's not on the last place, but it's important to mention it that it's a different part of the classification of diabetes. We separated from type 1 and type 2 diabetes. It has its own plate. It is defined as any disorders in carbohydrate metabolism that occur or it was first detected during the pregnancy. The definition applies regardless of the need to use insulin, or it doesn't matter if the treatment need to proceed after the delivery. The definition actually in the past has been focused mainly on the risk factors for the mother, what happened with the mothers, but the current focus is regarding what happened with the baby. So this happened after this hyperglycemia and adverse pregnancy outcome study, which was held back in 2008, and its aim was to clarify the relationship between maternal glycemia, milder than the one in diabetes, and the risk for the adverse fetal outcome. For the purposes of the study, it was more than 25,000 women which were included from 15 international centers, and the women who participated in the study performed 75-gram OGTT test between 24 and 32 weeks of gestation. The primary endpoints from this study was to evaluate the birth weight, need of the cesarean delivery, neonatal hypoglycemia, the cord serum, C-peptide levels, and the secondary endpoints were the preterm delivery, shoulder dystocia, need for intensive neonatal care, hyperbilirubinemia, pre-eclampsia. What the results from this study actually showed was a consistent correlation between the maternal hyperglycemia, which you can see in the blue line, the fasting blood sugar. In the yellow line, you see the first hour postprandial through the OGTT test, and in the red, you see on the second hour through the OGTT test the level of blood sugar. What we see there is a increasement in the risk factors for birth weight, the primary cesarean section need in each pregnancy, the clinical neonatal hypoglycemia, and the level of the C-peptides. It was correlated with the level of hyperglycemia. So the results from this study and the criteria from the study showed that actually they might be implicated throughout all the countries. So the FIGO Initiate, which was held in 2015, actually wanted to distinguish all the women who get the diagnosis gestational diabetes, to divide them into two groups: those who have clear gestational diabetes and those who have hyperglycemia that might be more advanced. So they made this classification and they separated the women with the hyperglycemia through to these two groups: gestational diabetes and diabetes during pregnancy. Those with diabetes during pregnancy, they might have diagnosed diabetes before the pregnancy, type 1 or type 2, or they might have diagnosed firstly during the pregnancy, which also could be type 1 or type 2. The difference between the two groups, actually, it is, we might say that the gestational diabetes most often happen in 24 weeks of gestation and further on. Apart from the diabetes during pregnancy, which might be pre-pregnancy diabetes or might be hyperglycemia, firstly detected during pregnancy, that meets the WHO criteria for diabetes outside the pregnancy, and most often happens in the first trimester through the pregnancy. Actually, this criteria applies for the women, and the hyperglycemia is important because those women who have criteria for diabetes according to the WHO criteria actually might need additional help with the complication throughout the whole pregnancy. So what we are going to talk about today is the reason for developing the gestational diabetes, the importance of the test of the blood sugar, how to test it, when to test it, how to control it, and how to treat it. Starting with the pathogenesis of gestational diabetes, you see this picture actually has many pathogenetic mechanisms that are included, but mostly we are talking about the insulin secretion, insulin sensitivity, and insulin resistance. Through the normal pregnancy, the increased insulin secretion is enough to cover the increased insulin resistance, but this doesn't happen in the cases of gestational diabetes, when the increased insulin secretion is not enough to cover the insulin resistant need. So the impairment might be in the glucose transport and the glucose uptake in the muscle tissue, and insulin resistant in the adipose tissue, which might be due to the progressive increasement production of the placental and other hormones. It might be placental lactogen, growth factors, progesterone, estradiol, cortisone, which increase the production of the hormones from the adipose tissue, the adipocytokines, which might be disturbed throughout the pregnancy. The disturbances might be also in the insulin transcellular activity due to the post-insulin receptor disorders, which might lead to decreased activity in the insulin receptor, decreased activity of insulin receptor substrate 1 expression, and decreased activation of protein kinase 3. So one really nice study back in the past show really what happened with the insulin levels and the insulin sensitivity in 4 groups: those who have lean, those who are lean controls, pregnant women, those who are obese control, those lean pregnant women who developed gestational diabetes, and obese gestational diabetes. They compare them in 3 stages: pre-gravid situation, in early pregnancy, and late pregnancy, and also regarding the insulin need and the insulin sensitivity. What is clearly shown here, that actually more obese the woman is, then the insulin level might be increased, and accordingly to this, the sensitivity actually is the one which is decreasing. we can't just miss to mention the autoimmunity in gestational diabetes, because in the 10% of the cases we might talk about autoimmune process that happen. We all know that throughout the pregnancy there is an autoimmune tolerability of these pregnant women, so she could tolerate the autoimmune disease, but still in some of the cases with the gestational diabetes, we might talk that this might be a type 1 diabetes that is uncovered throughout the pregnancy. Why is important to test the pregnant women for gestational diabetes? It is because the prevalence of glucose intolerance is increasing worldwide. And we know that more than 60 million women of reproductive age have already type 2 diabetes. And the prevalence of gestational diabetes depends on which country we are talking about, varies from 1 to 28%. In Bulgaria, in one big study that we have performed in more than 1,500 pregnant women, we found that the prevalence of gestational diabetes was 29%, and this was mainly because all of the women has at least one risk factor for gestational diabetes development. What are the risk factors? The risk factors, main risk factor for developing gestational diabetes was the overweight, the obesity, the family history of diabetes, birth weight of fetus above 4 kilograms, gestational diabetes in previous pregnancy, anamnesis of polycystic ovary syndrome, reproductive failure, the age above 30 years, multiparous women, and those who needed assisted reproduction for pregnancy to occur. What are the risks for the fetus? It's mainly because the fetus, it doesn't eat any sandwiches, fruit or vegetable. The fetus actually receives the blood sugar that comes from the mother. So this glucose is crossing the placenta, and it will stimulate the fetal pancreas to produce insulin, and this might lead to increased birth weight and diabetes fetopathy. In the future, this might lead to diabetes development. So the mechanism that helps to provoke this is through the increased fetal transfer of the substrates that might lead to macrosomia, decreased surfactant, increased tissue consumption of the oxygen, which definitely might lead to stillbirth, perinatal asphyxia, respiratory distress syndrome, hyperbilirubinemia. And the prevalence of causes of the glucose intolerance through the lifespan of this child will always show that there is increased risk for glucose intolerance that might happen in the early stages of the life of this child. So the risk, of course, also apply for the mother. It is for the weight gain, the development of the preeclampsia, the need of the cesarean delivery, and also the onset of the diabetes later in the stages of life. As you can see from this graphic, it's happened also here from the randomization. So you see even that often after the delivery, the glucose intolerance might happen. What we found that actually in our follow-up of these pregnant women who develop gestational diabetes, that 25% of them, they will keep this glucose intolerance. It might be pre-diabetes or the diabetes after their delivery. So when we are going to test the women, the gold standard and the strategy for evaluation the glucose metabolism throughout the pregnancy is to use 75 grams oral glucose tolerant test after 8 to 12 hours of overnight fasting. It might happen in the first trimester if there are risk factors for this condition, and if there are not risk factors, all women should undergo TOL GTT between 24 and 28 week of gestation. These are the accepted criteria for defining the gestational diabetes from the OGTT: the fasting level of blood sugar above 5.1 first hour, throughout the OGTT above 10, and on second hour 8.5. Only one value is enough to confirm the diagnosis. And when the levels of the blood sugar reach fasting above 7 and on the second hour above 11.1, which are the criteria for diabetes development, we might confer that we are talking about diabetes during the pregnancy. This is usually happening most often in the early pregnancy. In the countries in which there is not a strategic for all the pregnant women to perform OGTT, there are some factors that might help the clinician to decide who to screen or who not. And in these cases, the blood sugar less than 4.4 is actually the one that have really nice sensitivity to exclude the pregnant women which are with the lowest risk for GDM development. What about the glycated hemoglobin that we use it for as a gold standard for diagnosing and treating diabetes? We know that above 6.5 we are accepting diagnosis of diabetes, but throughout the pregnancy we really can't count on it as the same situation outside the pregnancy, because its levels might be decreased due to fetal placental glucose utilization, shortened half-life, and biphasic changes in its level, and the lowest level in 24 weeks of gestation. And since we already know how to screen and what are the reference intervals, now we will proceed with the treatment. Of course, this is multidisciplinary condition that needs the self-monitoring of the blood sugar from the pregnant lady. This needs diet, physical activity recommendation, the pharmacotherapy if it's needed, and of course the monthly checkpoints with the obstetrician. So if the health diet and the physical activity are not enough, then medication need to be implicated. So regarding the weight gain that it's appropriate for the pregnancy, we know that it is different using the different BMI before the pregnancy. So if the woman has the obesity with the BMI above 30 before the pregnancy, then the kilograms which are allowed to be gained throughout the pregnancy, they decrease. So what if we are using glucometers or sensor, which is the easiest option for the pregnant women? We need to achieve this control, that to say that we're really happy with the glycemic control of the pregnant woman. So this means that from this glucometer or sensor, we need to achieve blood sugar less than 5.3 fasting one, and 1 hour in the postprandial after eating should be up to 7.8, and on the second hour less than 6.7. If we reach this target, then we are really happy that the risk factor for this pregnant woman is really small. So the treatment should be directed to all blood sugar. If we are using the self-monitoring of blood sugar, it doesn't matter if there are glucometers or sensor, then that is enough for reaching good glycemic control. Regarding the diet, we know that we need to decrease the energy intake of the obese women. So we know that we want to reach a level of glucose which is not leading to ketonuria, and we need also to decrease the carbohydrate intake for those women. This will improves the insulin sensitivity, and this will improve the glycemic control. And if we compare two groups of pregnant women, those who receive recommendation for diet, physical activity, and receive pharmacotherapy if it's needed, compared to the control group, we will have really decreased level of the serious perinatal complication, of course, and decreasing of the perinatal mortality. And this is regarding the birth weight, large for gestational weak babies, more than 4 kilos, more for gestational age babies. The Apgar score will be better if in the interventional group hypoglycemia will be less and the respiratory distress syndrome will be less in the interventional group. So the diagnosis and the treatment of gestational diabetes will lead to decrease the risk of perinatal complication and the risk of macrosomia. How we are going to treat it? If we need to initiate the pharmacotherapy, then which is needed actually in 10 to 30% of the women who get the diagnosis, the safest option is to use the insulin. Maybe safe, they are metformin, glyburide, acarbose, and unsafe are the most sulfonylurea. We all know that insulin doesn't cross the placenta, so it's a safe option, and sulfonylurea and metformin are crossing the placenta. These are the insulin requirements throughout the pregnancy, and we know from the cases with the pre-pregnancy diabetes who need to initiate the insulin treatment in the early stages of pregnancy, the insulin sensitivity is the best in the early stages, and it increases the insulin needs throughout the pregnancy up to the highest point to the delivery, and then they are cut at the pre-pregnancy levels. So we might use different regimes, insulin regimes, with fast-acting insulin, long-acting insulin, in basal bolus therapy. This is what we decide how to initiate it, when to initiate it, according to these glucomers and sensor measurements that help us to promote a good glycemic control. Of course, if we decide that metformin, which is now the safe options throughout the pregnancy, we can't exclude the potential risk regarding the lactic acidosis, stillbirth, the neonatal hypoglycemia, and the teratogenesis and malformation. But in the biggest study that has been performed from this Australian group, which compare group using metformin and those who are using insulin, they actually found that there is no significant difference in the birth outcomes in the metformin versus insulin group regarding what they have found actually is the larger biceps circumference for the child. They have followed them on the second year after delivery, greater subscapular fold, greater biceps skin fold, but actually the percentage of the adipose tissue was absolutely without difference in the two groups which are using metformin on insulin. This study actually continue to follow the children, and they follow them up to 8 years of age. So they didn't find really a difference between the two groups, which helps to promote the metformin usage throughout the pregnancy. But still, the insulin is the first choice that might be initiated throughout the pregnancy, that is safe for the woman which can't actually manage the hyperglycemia throughout the pregnancy. So we need to achieve a pregnancy outcome in diabetic woman that approximate that one that we want to achieve in non-diabetic women. And I'm really thankful for your attention, and I'm happy to if you have any question that we could discuss it.
I would like to greet you all once again, this time live from Belgrade. And I would like to thank our speakers for outstanding presentations. We have a question for Professor Janić. How often do you use CGM in patients with type 2 diabetes?
Okay, thank you. Thank you for your question. Good afternoon to all of you. It's nice to be here. It's like that. In Slovenia, the CGM is reimbursed only for patients with 4 insulin injections per day. So at the moment, we use only for the insulin-treated patients with type 2, but we intend to start sort of a research project. I mentioned the Tabletka program. I don't know if you gathered all of it, but it's basically a structured program formed by our educational nurses. It's based on healthy lifestyle, diet, exercise, and so on. And we intend to start giving these patients also CGM in order to see how if the outcomes of them are better in comparison to those using only blood glucose monitoring, pinprick tests. So based on that, maybe we will have some national data in order also to expand the usage of the CGM in type 2 diabetes. But at the moment, as I said, it's reimbursed only for those treated with for daily
Type
insulin
1.
and type 1, of course, but those who are on insulin in type 2, they need to have 4 injections per day. They also get the reimbursed CGM.
Okay. Thank you, Professor Janić. For Sister Jodi Aigner, I wanted to ask you, do you have some kind of structured education for patients starting insulin therapy? And do your sisters have role in insulin titration?
Sorry, the second part of your question is about...
do the sisters have a role in insulin titration?
Yes, so they get very, very much involved in insulin titration. It's part of our what's known as self-monitoring, self-management of or self-management of diabetes. It's very important that the patients get involved right from the beginning. So from the time they're diagnosed, our guidelines in South Africa, SEMSTA, very much aligned with all the guidelines around the world, and suggest that these are taught literally from diagnosis, when the patients are taught what our targets are going to be, and if patients are coming in, that they know that they are going to likely need titration, and a general guideline, but certainly our nurses are involved initially to get the patients started, and then the patients get an idea of where they need to go, and very much structured education. They come back quite frequently. We have a 2-tier system in South Africa. We have the government public sector, where it's really the funds are pretty low, and then a funding from a private sector where the medical aids will actually reimburse twice a year visits with us as nurses. So you don't get a frequent update, only twice a year. So the patients have to rely on themselves. We have to upgrade, we have to update them.
Thank you very much. For Professor Gül Yeşiltepe Mutlu, I think that you pronounce it well. Do you have transition clinics in Turkey? Do you have transition clinics in Turkey? And if you do have, are they both pediatrician and adult endocrinologists involved, or you don't have it at all?
Actually, thank you so much for the question, and it's great to be here. Thank you for the invitation as well. Actually, there are some transition clinics in different departments in Turkey, because it's a big country and there are lots of centers. But in our own center, actually, we do not have a transition clinic, but we are in a very close relationship with adult endocrinologists. But it's an important need for all of us. It sometimes gets difficult to refer our patients, and we are working on it.
Yes, we have the same practice here. We don't have transition clinics per se, but we do only have relationships with our pediatrician endocrinologists. But I think that they are very much needed. Thank you very much, Professor. For Dr. Tudor Cosma, Have you had experience with overdose in persons who use insulin as anabolic in gyms and etc.? Because we know that they are widely used there.
Thank you so much for this question. No, I didn't have any case, only patients with diabetes who are treated with insulin. I think that this person who use the big guys that go to the gym usually inject
Smaller doses.
Yes, lower doses. They read a lot online. They have like all kind of doctors that advise them, or nurses or things like this, how to administer a few units of insulin at the beginning. They use rapid insulin. Now they are using long-acting insulin in order to decrease the incidence of hypoglycemia. But no, I think that these patients, they reach only to emergency department. They don't get on endocrinology departments. They are managed in emergency rooms. I don't think that they end up in endocrinology.
Okay, thank you. And for Dr. Maria Bojađieva, what is your treatment plan for pregnant women who come, who were on metformin before conception, and they come to you for the first time? Do you stop metformin? They had insulin resistance or whatever, they were on metformin, and when they first come to you, do you stop metformin or you wait? Or if you stop it, when do you do that?
Hello to everyone, and it's really nice to be here with you. So according to the patient that comes to visit me and are using metformin before the pregnancy, one thing that I could say that they're really motivated to keep all the recommendation that we are giving them. So in case to be sure and safe for the baby, they're eager to do whatever we say. And according to many of the guidelines that we know regarding the pregnancy, most of them recommend to stop the metformin treatment after the pregnancy is confirmed by the obstetrician. So this is our current vision, and we are stopping the metformin usage. When we have the positive test for the pregnancy, we start to decrease the dosage, so we don't make it that we cut it in the right moment. We decrease it step by step, and we suggest to the pregnant women to start measuring each day the values of the blood sugar using sensors or glucometers. Depends what they decide, because they are not reimbursed for the pregnancy in Bulgaria, so it's up to the pregnant women. And if the values cover the threshold that are set for the pregnancy, then we switch for the insulin therapy.
So you don't stop metformin if immediately?
We stop it.
You stop it?
We stop it with the confirmed pregnancy, which means around 7 to 8 weeks of gestation. And if the pregnancy is confirmed by pregnancy test, we start to decrease the dosage of the metformin. And if it's confirmed, then we stop it completely.
Okay, and you retest them at the 24th week or not? Do you retest them?
We start with the measuring of the blood sugar just to see if everything is okay. And if everything is okay, then we could retest them using the OGTT test.
Okay, thank you very much. We have one more question. Just what dose of vitamin C intake will interfere with the blood glucose readings? And which glucose meters are affected and which type of technology? I think that it's for Professor Janić as well. Maybe
so
for
I know
CGM.
if I can jump in there, that was to do with the accuracy of the meters. So that also interested me. So when I look back to see how that actually affected it, the trial, the study showed that there were quite high doses of IV vitamin C, and it was used in burns patients as an adjunct therapy in sepsis. And we're talking about 100 to 150 grams, and that tended to affect that elevated the blood sugars. So, I mean, to give you, like, if you want to put it in context, I mean, if you want to treat a patient who's got hypoglycemia, we recommend we recommend 15 grams of sugar, which we use super C sweet, so which is 3 to 5 of these sweets, which is 15 grams, and you'd need 50 of those. So we're talking about quite high doses. So it's not specific to any particular meter, but it's more to do with the actual the elevated levels of vitamin C. The hypoxemia was the one that was more related to a chemical reaction that occurs, and that may be affected by certain brands of meters that use a chemical, and that chemical was some GDH.PQQ. And I mean, and I was only aware of one meter that used this chemical reaction. If anybody else,
thank you. We have a question regarding CGM and pregnancy. Maybe someone's comment on that. CGM in type 2, gestational diabetes. What do you think about CGM in pregnancy?
I could answer this. I might take the question. I completely agree that the CGM, they are completely needed for the pregnancy, because the values of the blood sugar, they're changing not month by month, they're changing not week by week, they're changing every day. So this means that using the CGM for controlling the blood glucose will be really in need and really helpful for our treatment and our covering throughout the pregnancy. So definitely I think it's important, and we will do our best to initiate the national health system to cover it throughout the pregnancy.
Thank you. We don't have any more questions. At the end, I would like to thank Essentia for organizing this really constructive and valuable meeting. A big thank to our for our faculty, I think, yes. And thank you for wonderful presentations. And at last but not the least, thanks to all participants. And we are all looking forward to seeing next year. Thank you very much.
thank you.
Thank you.
Thank you.